Welcome to another edition of Throwing Out Some Heavy Light. My name is Aljamal Rashad Biden. I'm the chair of Movement No More for Race Equity, oftentimes known as MORE. And our organization is concerned with race equity issues, transparency, and accountability, and how we can get more community people involved in challenging systems and also talking about issues that can help bring our world together. And today we're going to talk about health issues. And over the past few months, we've seen challenges in healthcare, including racial diversity, low-income families, inability to obtain affordable health care. There's a pushback recently about Obamacare or the Affordable Care Act, and there are other factors affecting things related to life loss in our community and in our country. And many families don't have insurance, they don't have exactly the income, and also they don't always have community education. And again, these are things that we can help them improve their lifestyles and so on. We invited two individuals on our program to talk about ramifications and solutions for moving beyond the medical industrial complex, or the industrial medical complex, how you want to put it, because we've seen challenges in healthcare recently, more so that deals with racial diversity and low-income people's inability to afford healthcare. And again, like there is a current pushback to Obamacare or the Affordable Care Act and other factors affecting many people in our community and so on. We invite these individuals to help us with that. And again, they're going to talk about some of their issues. And by the way, I served for a number of years on the Nebraska State Health Department board and dealt with some of the issues related to managed care and so on back in the day, and attended many conferences and also workshops and learned about things that could help benefit residents in our state. And many of those community forums and events were very helpful to those community members who participated because it was able to help us deal with credible messengers, as well as to talk about research studies and also the trends that can help us improve our lifestyles as Nebraskans. These two individuals, I have Andy J. Wessel and Dr. Melanie Menning, who are been known for their work, and we want them to be open to questions. I'm going to ask them questions for about 30 minutes about different issues and so on. And then we're going to open up to participants to ask or raise questions directly to them with comments and so on. And so first, I'd like to start off with both of you, Dr. Menning and Andy. If you could kind of share a little bit more about yourself, and then we'll get right into the questions.
I will go first. So my name is Melanie Menning. So I am a native Nebraskan. I've been here my whole life, started in rural Nebraska and made my way to Omaha for med school quite a while ago now. I am a mother. I'm a wife. I also am a physician. So I am a primary care physician in town. I also um, have a big interest in public health and thinking about how do we look at system issues more than just the individual and how do we make healthcare better. And so, pleasure to be here tonight.
And Andy Wessel, my day job is that I work at the Douglas County Health Department, not here representing them in any way, just here as an individual. But I've been with the Douglas County Health Department as a community health planner for over 15 years. The complicated way, the grad school way of saying, talking about what I do is I work on social determinants of health. That's just a fancy word for what we normally actually call living conditions. So like housing and transportation, education, real estate development, all of those things that are important, have health implications, but we don't often think about them. So a lot of times my job has been talking with people about health when they don't realize that they're actually working in the health sector in a way that they just don't realize. The other thing I'll just mention is that prior to I was like a UP kid, moved around a whole bunch. As my dad moved with Union Pacific before coming to Omaha. And then I'm a boomerang. Like I left, went to school, spent 5 years in Detroit. That's a whole interesting thing of getting out of my racial comfort zone as a white guy. That the 5 years living there did for me, and then boomerang back to Omaha. So that's enough to get started.
Good, good. Now, I want to start off with we're in a country that spends an inordinate amount of money of healthcare and public funds in that whole area, more than many countries. And some even argue, how come we can't have better healthcare? My question is that some people say if we cut out the insurance companies and set up a single payer system, we could save many lives in our community and society. What is your assessment or your perspective of a single payer system and maybe moving to something like that from your vantage point?
I
You
can take
first,
a
Melanie.
stab first, would be happy. It's complicated. It's really complicated. Um, One of the things that sometimes gets left out in that statistic, we spend way more than any other country. And our health outcomes, we aren't paying for the benefit, right? When we look at health outcomes, our benefits are not better than people not paying that amount of money. Um, and again, I'm coming from a biased lens. I am a primary care doctor, so prevention is one of the things I really believe in. When we look at other systems, a lot of it comes down to where we put the emphasis. Do we put the emphasis on once people have disease, trying to um, sometimes do big grand gestures to save people versus putting emphasis on the front end? A lot of those countries really focus on the front end, meaning do people have healthy food to eat? Do they have a safe place to exercise, a safe place to live, a safe place to work? Um, do they have access to care? And so a single payer system, there are benefits and shortcomings of both. I think in our system, one of the things we have to look at, though, is a single payer in and of itself. If we continue down the I'm only going to put the brakes on once you're already sick standpoint, probably isn't enough to actually get us to where we want to be for our health outcomes.
Okay, good. Now the other thing is, I know. Well, Andy, did you want to share something sir, about that?
Yeah, I want to jump in on this one too.
Oh, okay, hold on. Now, we got to figure out now how we got to jump in. Go ahead.
Yeah, so just so you know, it's about 18% that the United States of gross national product that goes to basically health costs in the United States. And most countries, again, are spending about half that. So the peer countries are spending about half that. And again, our outcomes aren't as good. And again, most of the other peer countries, they have some form of, guarantee for health coverage that we don't have. And I think the issue there of why we don't have some sort of guarantee for everybody goes back to just the nature of our struggle with our history and with the racism and oppression that's been built into the history of our country. So it's that thing of like, why don't we have a commitment to taking care of everybody, figuring out how that gets paid for? Because again, care is different than coverage. But the fact that the commitment to everybody isn't there is both reflective of why there's not a single payer system, or at least some form of guaranteed care, and at the same point is a big part of why we don't have as good of health outcomes, because we essentially leave big gaps in our coverage, in our care, that then let other people fall through those cracks, get sick, and then we're stuck with that thing of treating people when it's harder because they're already sick.
Yeah. One thing I want to switch up a little bit. We live in a community, and I know both of you have extensive contact with low-income people and people of color in the work that you do. And we oftentimes see these medical entities, healthcare, you name it, that don't always incorporate some of those underserved population in the conversation. I also know that you participated, both of y'all, in listening sessions or building relationship with people and so on. And my question is, how do you bring some of their ideals into help challenging and make the system better? The reason I throw that out is there's that statement that says those who are close to the problem are close to the solution. So how do we do it and reverse the paradigm that the people, we need to bring them in, and particularly those of color and those who are low income?
Yeah,
I can
I
go
think
first on
that.
this one.
Oh, go for it. Sorry, Andy.
We can tag team off. The Some of this goes back to like how we conceptualize leadership and expertise. And a lot of times what that boils down to is if you're in a leadership position or an expert position, your job is to be the one doing the talking. And really switching that dynamic to true leadership is often doing a great job listening. And it's only when you're willing to do that job of listening to other people that you can, to your point, hear what the solutions are, that you can have your perception on things, knowing that you don't have all the answers and that there are plenty of people smarter than you or that have some perspective that you don't have, that it's possible to do that. And one of the key pieces is like making sure that we're actually figuring out the decisions that need to be made, and then going out and engaging them. We do lots of engaging people, surveying people, all of that sort of stuff, where we collect information, but then we don't have a place for it to go and make a difference. And so that's one of the key pieces is like you have to have a clear question, a clear decision where you're like, we could go left or we could go right. We need you to help shape that with us. And then work with people to then make those choices in a way that is informed by them. But I think it fundamentally goes back to, do you value people enough to truly listen to them? Or are you letting your idea of expertise or leadership get in the way of that?
Dr. Melvin?
Yeah. I think Andy said that very, very well. A piece that I would add is, when we think about healthcare and where decisions get made, and part of this is a result of not having a single payer system and having ways that people can profit from healthcare in this country. Sometimes the question is payer mix and things like that, and that's where how it gets decided where new clinics go or where interventions go and things like that. And I think we really need to work as a system to get, to Andy's point, more people in the room where those decisions are being made and who can offer diverse perspectives on this while obviously we don't want hospitals to close, we don't want them to go bankrupt and things like that. There is more to this question, and it really comes down to how do we actually improve the health of our communities?
Mm-hmm.
And that may not always be in line with the most financially beneficial objectives a system can take. And so I think it's out, number one, how we get that diverse perspective in the room. To Andy's point, how do we collect data, actually use it? Because we often ask questions, but then don't necessarily follow through with what the response was. And change our emphasis to being, okay, we want the whole community to be healthy, and how do we go about that?
Mm-hmm. I was some months ago, I participated in a community meeting and discovered there's a tremendous gap between the health community education, some of the latest research, as well as some of the models that are coming out there, not only in the academic level, but elsewhere. And I was also, I'm not going to throw any names out, but there was some person they brought in from out of town who was brilliant, but they didn't think to record it or share it with community members, this particular person who was talking. So my question is, how do we deconstruct the literature or latest trends to help populations? Because again, there's a gap between the academicians or the health providers who are physicians and so on, and those who need some direct information. And again, it's related to the previous question I asked, but how do we narrow that gap so that we're not talking above people's head, particularly when dealing with some literature that affects our lives and our community, and particularly as the state of Nebraska?
Well, first on this one. I think that's a great point. And one of the things in the research work that I am doing that we really want to emphasize is dissemination. And when you look at typical researchers, that usually means putting an article using really big scientific words in a journal that no one's going to read other than really scientific people.
That's true.
Or going to a conference and talking to only other people who are studying the exact same thing, right? And I think one of the big gaps in our research is that dissemination back to the community, right? We're relying on the community to help us find the answers. We then don't give the answers back to the community and say, okay, now knowing this, what does that look like through your lens? How do we implement this in the community? How do we make it more effective? If we had areas that didn't work well, why do you think that was?
Mm-hmm.
And how can we do better in the future? And I think that's a big piece we're missing right now. And a way we could, as a community, move forward together, sharing those two expertise perspectives.
Mm-hmm. Andy, did you want to say something?
Yeah, I was going to say, like, the world of academia is interesting because you might have heard the phrase publish or perish. Mm-hmm. It's that idea that you're incentivized and you're measured for things like tenure on how many articles that you've published. And it's really sort of a like crude measure for how impactful and valuable your work is. Mm-hmm. And again, it's not necessarily getting to the point of, is what you're doing making anybody's life better? Is it improving, the health of our community, all of those sort of things. So I think that's one of the things is like, how do we figure out, like, there are plenty of researchers who want to see, who care about their community, that they live in and work in and want to find ways to do research that's meaningful, but they're often having to swim upstream against the currents of the institutions they work in to
Right.
actually do that kind of community-based thing, because it takes time to, to do things like build relationships and build trust and get to that point where that work would be impactful and meaningful, and it's based on really being informed by community. And when you don't have, the full support of the institution that you work at to be able to do that, it makes that really difficult. um, there's some of the challenges in public health, and that public health is a little bit more of an applied field, in a lot of ways. And we sometimes, like I joked with that social determinants of health being a grad school term, sometimes we're trying to use all these fancy terms because we want to show off our expertise and seem like we know what we're doing, when really often the more important thing is to figure out how to communicate in ways people can actually understand. And that's not talking like, uh, somebody with a master's degree or PhD. It's talking in a way where regular people can understand what in the world we're actually, saying. But that's that thing of like, do we actually speak community, or do we just speak public health, or just speak medicine? And realizing that there's, a language gap there, that we almost have to treat it like translation interpretation is necessary here to not just speak data, or not just speak public health, or not just speak medicine. We need to figure out ways to speak community.
As you say that, one of the things that come to mind is Malcolm X. He had a way of being able to communicate with people who had very academic skills, but also with grassroots of the little person. And so one of the things that he would oftentimes say is make it plain. And so one of the things I've seen in the past years, I've looked at some research studies from some of the academic people in the medical community, and some of the stuff I would not support in terms of the way it was laid out, but also a lot of it could be translated. They've made more plain that people could engage in with them directly. And again, it's hard to do research on a group, whether it be people of color, low income, and they're not in the room, which leads me to my next question. In many institutions in Nebraska, we do not have proportional representation of people of color. You just need to walk in any of our institutions, particularly in the health field or public health and so on. And those who we have sometimes don't always communicate, or not credible messengers. What can we do to increase affirmative action or proportional representative people of color in the health field? Because again, if you look at a lot of these places, they're not there, and then oftentimes they do get through with their degrees, they run to other parts of the community. So from your vantage point, how can we improve that diversity in our state and also some of our healthcare facilities? I see you smiling, Andy, over there. Ah.
Um, you know, I think this is a multi-pronged approach. I don't think it's a one size fits all solution. I think often our efforts have been very guided on that graduate level program. And what we see is that's way too late to start trying to build people up to health careers, right? We need to start when kids are in elementary school, middle school, and introducing the idea you can do this, and making sure they have science backgrounds and get exposed to that early, and get exposed to the wide variety of healthcare careers that are out there. Then it's encouraging our middle school and high school level counselors to sometimes kids aren't told you could do this, like you can do this. And they need to be given that reassurance of you can go to college. You might be the first in your family, but you can do this. And these are the ways to do that. And I'm going to get you connected with mentors who can help guide you in some of that processing. And then once we get kids in, figuring out how do we help them stay in. Right now there is a ton around loans and other things like that make a big difference in it's really dangerous to get a kid into med school and paying, we're public tuition options in Nebraska, but it's still really expensive, and we want to make sure those kids are successful once they do that. And so I think it's lots of different factors that have to go into it to make it doable.
Mhm. Yeah. And you want to say something?
I was just going to add, like, a lot of times when I'm meeting new public health people, I'll ask them, how did you learn about public health? Because people grow up knowing about, a doctor or a nurse, that sort of thing as a career option. And one point to just make is there's lots of other fields in the health sector which again are generally secure, well-paying jobs. At least a lot of them are. The so it's a good field. It's a growth field still in many ways, which gets back to that issue of like why it's so expensive. But um, the thing I would just add is like many people just don't know what public health does. They don't know, what it means to focus on community health. It's some of that thing of like, it's easier to understand tackling things at an individual level or a reactive level. You get hit by a car, like, oh, an ambulance comes, takes you to the hospital, you go to the emergency room, whatever. We've got TV shows to show you all of that. Like, great, very dramatic, like, makes good television. But the stuff of like figuring out how you design that street so nobody gets hit by the car in the first place there, or so that, it's a place where there's lots of people walking so that the cars know that they can't just assume they've got the right of way. Like those are some of the things that people don't think have an important, health impact on their community. But like those are all things that are key to the health of our community, that there's lots of ways to tackle that. And you don't have to do it in government. You can do that same kind of approach in healthcare, but you can also do it in nonprofit work, philanthropy, all those sort of things. So there's lots of opportunities, but many people just don't know that those paths exist that they could go down.
I was on the State Board of Health way back in the day, and like I said earlier, and I got to learn a little about the issue of years of life lost, premature death. I'm not sure if they're doing it today, but the State Department had some great data material on Nebraskans and some of the morbidity rates and so on related on cancer, heart disease, strokes, and so on. And they had it based on race also because they had an office called Minority Health down there and so on. And my question is, if you were trying to address some of those issues from your vantage point, either as a physician or as a public health worker, what are some of the things, low-hanging fruit, would you address or challenge, look at to help us increase the years of life loss in Nebraska? In other words, to reduce the years of life loss, rather.
So one of the things that we look at with this is that when you like make sure that a child makes it to their first birthday, fancy term for, infant mortality. That's now somebody who is probably going to live to be, 75, 80, that sort of thing. So when we lose babies, that has a huge impact on those figures, on our life expectancy figures, on our, years of lost life. So that's one of the things where we see really stark racial disparities. And so has to be a focus on the work. There's the piece that goes in with that of like, to do that well, you have to focus on the health of the mom, which we also have disparities when it comes to maternal mortality that really have to be addressed. And then it's like, what's the support system? How do you support the family? How do you support the community to be able to do a good job? So that maternal and child health piece is just a linchpin place to do well. There's a reason why, along with life expectancy as one bookend for public health measures, like we judge the health of a community really based on life expectancy and infant mortality. So that's a key one. And the other piece is like where we often also have major impacts that are the things that happen in young adulthood, early adulthood, that aren't somebody getting to, 75 and dying of a heart attack, end up being, the suicides, the drug overdoses, homicides, car crashes, all of those sort of things. And many of those things, we don't necessarily make a connection to the mental health side of all of that, the emotional health side of it. But if we figured out how to do a better job with all of that, many of those things would end up being improved too. So whether it's drug overdose deaths, whether it's suicides, whether it's homicides, the mental health connection is a linchpin for all of those.
Dr. Melanie?
Yeah. And again, I have a primary care bias on this, but when I think of the health issues, I think a lot. Sometimes we get really focused on one particular disease state, and often the problem is we're already too far down the road, that there are things we can do, but a lot of the damage has already been done. There's a study many years ago that came out that said, not that people shouldn't be doctors. It's a great career, you should do it, but only 10% of what I do ends up impacting your life, right? Life expectancy. There is a lot of factors, a little bit's genetic, but most of it goes back to the basics of, did we have a safe environment? Did you have safe and access to healthy nutrition, to exercise, to access to care, things like that. And so I think a lot of our focus when we're looking at improving overall lifespan is a focus on making sure we're doing the basics well. Before we get the big fancy, really expensive drug, did everybody get food today? Did everybody have a chance to get fruits and vegetables and things like that? That set us up to be better at being healthy and well from the start rather than just treating disease.
We're always looking at the issue of, oh, did you want to say something, Mandy?
I was just going to say, like, a simple way of thinking about that is like, how much time do you spend in a doctor's office versus how much time do you spend in your homes, in your neighborhoods, at your workplaces, for your kids? How much time do they spend at schools? Like, those are the places where we have the biggest opportunity to make impact, because that's where people are actually spending their time and where they're having the exposures, good, bad, that are going to, actually impact their health.
Well, one of the biases, or I use a bias, I like that term today. I got a bias. I'm just almost crazy about this. We need more community education, forums, and also places where we can avoid that white savior mentality. And I know some people debate, is YouTube a good place for resources to learn about medical information or public health and so on? And sometimes those of us who out medical degrees or, or lay people, how can we learn about some of these complex health literature? And I'm sure if the internet's the best model, but from your vantage point, how can we disseminate information out to folks from a medical model or public health model that could reach the masses? Now, some people talk about Instagram and Facebook and so on, but from your vantage point, how can we do that and make it a little bit more flatten the pyramid, as we would say?
Melanie, you want to go first? You want me to go first?
I'll let you take that one first. I'm not a good Instagrammer. I don't have a TikTok, so I'm going to let Andy own that one.
Okay, gotcha.
So the amount of people who are getting medical advice off of TikTok or Instagram or just Googling stuff is astounding. And so part of it's the reality of those are the places people are getting information. There's a challenge here that, again, to be professional and credible almost equates to being boring. And then nobody's going to actually come check out the information you're trying to share. So that's a challenge for us. Like I say that working, for the day job in a government agency of can we actually find ways to be relevant? And some of that is, we can't share information in a 50-page report and expect that anybody's going to read it. It's got to be that thing of, again, having communication with people that actually meets their needs. But that means we have to change, and that's a area of growth for us to be willing to do that. And I'll just add that part of this is also the whole issue of trust. Who do you trust? And how do you figure out who's trustworthy? And the reality is many of our institutions haven't done a great job of demonstrating trustworthiness. And then it becomes problematic because we're no, don't listen to the crazy person who's just trying to take your money and basically selling you snake oil. But if we don't have the credibility for people to say well, of course I'm going to believe you versus them, so part of it, again, is that piece of building relationships and building trust so that when we do have the communication, the dialogue back and forth, we're in a position where we can have a real conversation that's both respectful and does a good job of listening to what people's needs are and communicating in a way that actually makes sense.
Yeah, Melanie?
Yeah, I would echo what Andy says. Two things I think I would highlight. I think for example, when I got taught to be a doctor, I didn't get taught how to go talk to the community and do things. And I think that is a major
Wait, hold on. You said you got a special course on that when you take medical school and law school?
there's not. There is not. But we're realizing maybe there should be,
Right.
and how to do social media and things. And that is one of the things that is being brought into the medical curriculum now of how do we talk to real humans and not use all our medical jargon and just create more confusion and more often distrust. I think to Andy's point, it's also about showing up, right? You're showing up the day in and day out. You can't just be there when there's a sudden new disease or other things. We need to be consistently present and consistently with people and having conversation. The other thing I really like is community health workers and promotora models. I think we often make the health stuff sound way more complicated than it is. And there is a lot of this that we can teach up to community members and teach up to people who are trusted within the community and who can also add a different lens to it and understanding and help with disseminating that information and getting it to others and starting that conversation.
Good. By the way, we're right up on our 7:30 mark, so I want to be attentive to participants having a chance to weigh in. So at this point, and I got another question too, but I can come back around later on if we need to. But I want to give people in the audience or participants a chance to ask a question of either or two guests here. So open up and you can use the chat and whatever and go from there.
Ajmal, did you see that there was one in the chat already?
Well, I don't always see too well, so I'm put my glasses back on. But yeah, let's go and go for it, y'all. And
So
folks,
it
we
says,
also encourage you go ahead.
you finish the lead in, Ajmal.
What I was leading to is basically, folks, if you want to say it, feel free to make your mic unmute and say directly to the participants or to our guests. And again, if need be, we'll read it from the chat if need be. So let's go forward. There is one right there. Do you want to speak to the issue here, Normie?
Yeah, so what does supporting maternal health look like? Does it include providing nutritious food for mothers and babies, education, other types of support? All of the above. I mean, it's basically saying if you're doing maternal and child health well, there's a whole thing of like preconception health that means like before mom gets pregnant, like we want to make sure she's as healthy as possibly could be. And then it's the thing of all the follow up of like the prenatal visits and the stuff like that. But then it's also the follow up after the baby goes home. And so it's the piece of like home visitations, the support like that. It is having the things in place to be able to connect people with community health workers and then to be able to connect to resources. They can do that. And it's just a part of it. Goes back to that thing of like, would you rather spend the money dealing with the bad implications of not taking care of things up front? And we recognize that period of pregnancy, new birth, first year of life, like is such a like critical time period that we have to invest in it and get it right. It's like it's such a smart investment to get that time right.
I see Paul has a question here also and from Facebook, and he talks about, man, my eyesight's a little bit off. Support can you health support programs to promote you may have to provide and support to stop sending babies home in poverty, upstream intervention, and so on. Basically, how can we bridge that gap in terms of helping families who have kids come from the healthcare entities and so on, so that they can deal with some of those issues and then he talks about doulas and so on, Black doulas. So can we speak to that a little bit? Can help programs help people who are coming out of the house with their children to do more with their bringing the babies home and not send them without that support? Basically is what he's asking.
I can't comment to Douglas County, but I can comment on yes. And I think there are models that are starting to get that, right? And some of this goes back to the idea of what do we fund? We finally got Medicaid approval to cover doulas and things like that. We are seeing some insurance start covering food programming, foods for moms and things like that. And so part of this may be on the county, but thinking outside of even Douglas County, how do we make sure across our state everyone is getting access to this? It can't just be a metropolitan thing, but This is affecting everyone in the state. And so how, can we make sure all individuals who are affected are getting.
By the way, some of us don't even know what the word doula means. Can we break that down, what that's all about? I mean, I'm serious. Some people have never heard of that probably.
Yeah, absolutely. So a doula is someone who does have some not usually medical specific training, but training around pregnancy and around giving birth and around that postpartum period. And it is a support person for the mom and
Mhm.
an advocate for the mom, right? This is someone who lives in between community and the hospitals and the clinics, and they can really advocate for patients and make sure they're getting the best care, making sure they are understanding what's going on, and can be active participants in the decision making that goes around prenatal care and having a baby.
Okay, good. And did you want to say anything on this one here from a public health perspective?
No, I was curious about, I mean, those are things that I'll just like highlight that, Ivy Black Girl is doing some really important work, and it's so necessary that they're doing the work that they're doing and the partners that they have to just push on at the maternal and child health issues. There's a group called City Match that's here in Omaha, but they work nationally on maternal and child health, and they've been doing great work, again, across the whole nation in urban settings, to focus on maternal child health. And I would say one of the things that's really powerful about maternal and child health is that they are often the vanguard on pushing on important things that need to happen.
Mhm.
But they're often, again, not prioritized and not funded in the way that they should be. Seeing some of that change to that point of like the home visitation, the investments in doulas, again, seeing midwives be more of a thing that it has been in the past. And so getting a little bit away from everything has to be a clinical approach to how do we provide social support and that piece of like moving things further upstream.
Go ahead, go ahead.
And the last thing I was going to say, like another model that is relatively new is that you should look into is the Pathways Community Hub. That really is that piece of like how do we use community health workers to make sure we're improving birth outcomes.
By the way, the other question that came in was, oftentimes they'll look at some of I want to use the word provincial or narrow-minded mentality, something that we may do in a certain part of the country or certain areas. And one of the questions raised here is, are there some models in other places, in other jurisdiction that can help us improve some of the healthcare indicators and things that we're talking about here? Because I do know when I heard that lecture by the one physician, yeah, and they talked about what happened in Detroit in Chicago, and then in Florida, and some different models. And my question, basically, which is asked here, is that are there models or things that we can look at elsewhere that we can incorporate in Nebraska to help improve some of our healthcare indicators or outcomes?
Yes, there are. If thinking around the child things, the giving food to pregnant women, that has been studied and showed positive outcomes. The doulas have been studied and showed positive outcomes. Um, uh, there are a number of things. One of the primary killers of women in childbirth is preeclampsia. That's when the blood pressure gets too high, but besides the blood pressure, it causes lots of other things like seizures and lots of problems. And it can happen even after you've had a baby.
Oh, wow.
And our recognition of that is not great. If we look across the state, our access to maternal fetal medicine physicians is not great, not equal. And we know these things. And there are lots of models out there where people have been successful in addressing some of that, and models that could be adapted to Nebraska. And people are exploring that, and excited to see in the upcoming years. I hope we will make some changes there.
By the way, something came to mind as you were talking. I remember when I was growing up as a kid, I'm from a family of 14 children. And my mother would stay at the hospital like 3 or 4 days. And again, when my wife and I came and had our kids, they'd kick us out like the next day or something. So one of the things you got to be careful is you don't want to get the person out of the hospital or the healthcare too quick before you, again, dealt with some of the complications. But back in the day, we stayed out a little bit longer when we were having childbirth. And then lately, it's almost like within a day or two. And I'm not sure if that's a medical model or it's an insurance model, what's going on. But I do know some health complications, we need to be sensitive to that. But what is the going rate? Is it like 2 days when you have a baby now? They expel you? I mean, I use that word expel, but they let you go home.
Depends a little bit, but after a vaginal birth, 1 to 2 days is not uncommon. After C-section, usually more like around 3.
Okay, got you. Did not know what's going on today. Good. Other feedback, other questions, other participants. There are other folks on here. We can ask direct questions of our guests directly. One of the questions I was going to ask you earlier, if you had a magic wand and you had to deal with the healthcare entity systems or whatever, what would be something you would say to those folks out there that would help them improve dramatically quickly? Again, we're using the word magic wand here that they may not be aware of from your vantage point or from your experience or expertise that you've brought to the table.
I would say, look at where people spend their time. And so if you could get housing right, and if you could get basically work right, or school, which is the equivalent for kids, if you could get those environments right where those places aren't damaging us, and that's part of what happens. The patterns of oppression and exploitation are still built into our work systems. They're still built into our education systems and all of that. And then they treat people as if they are means to an end rather than a person with their own innate worth. And when that happens, then people get damaged. We're decent now at making sure that physical damage isn't happening. You go to your boss's office, you come out with a broken arm. That's probably a lawsuit, and somebody's going to get fired. But with the equivalent of that happening to you mentally and emotionally, that's all the time. That's a Tuesday. Mm-hmm. So I think those things of if we actually could get the housing piece figured out where people could afford, humane, safe, affordable housing, that's critical, because that's so much foundation for everything else. But also, where do people spend time, work, and school, making sure that doesn't damage them? The sort of the do no harm in those places, that would be incredible.
Mm-hmm. I see there's another question jumped out here from Paul. He says his dad had a home health machine to take his blood pressure, weight, pulse, blood, and so on, remotely monitored by the nurse. You see that as a way that can help address that, Dr. Melanie?
Yeah, no, there's some cool things, right? Technology can be cool. It has to be used responsibly and has to be well thought out. But there are some cool things that can really change the way we think about access. And it doesn't necessarily have to be that you have to make an appointment and take off work and show up at a doctor's appointment within 10 minutes of your visit, or it's going to be canceled, and all of the complications that we as a system add to healthcare. And there is more and more that we can be doing from remote monitoring, like Paul is describing. And so I think there is a lot of excitement around that, and it can really change the way we think about healthcare.
Someone asked here, how do we support seniors with better eating habits or becoming actively, especially ones with chronic diseases? Sound like a gerontology one of tactics.
I'm gonna say this was focused mainly on single moms, but the Financial Hope Collaborative, this is what they found with their work is that when people actually were able to stabilize their finances, and then they would be less stressed, because they weren't dealing with people calling the bill collectors, debt collectors, calling them all the time. They had a plan for where their money was going. Mm-hmm. But just that piece of not being stressed out all the time has huge, benefits in terms of people's health. But then they were in a place where they could make, better decisions around food. So we talk about this all the time of the expectation that people are going to be able to spend extra money on healthy food, or, all of those other sort of challenges. If people are in survival mode, then they're in survival mode. And so that's the key thing is we have to find a way to provide people with enough stability at whatever age they're at to be able to make good decisions. And then people are people, and some of them will make great choices and some of them won't. But the part of it really is enough financial stability so that you're not stressed out all the time and you're not in survival mode.
Mm-hmm, mm-hmm. By the way, Dr. Pope, did you want to say something, Melanie? Go ahead.
That's okay. I was going to echo what Andy said. So when people are in survival mode, we know from a physiologic standpoint, it increases a hormone called cortisol, and that hormone damage does significant damage to the body. And I tend to, that's the public health in me, has, as Andy, think of how do we as a system incentivize making the healthy choice the easy choice right now, that's not often in our society. The less nutritious foods often are cheaper, more affordable, easier to make. And so thinking through some of our systems of how do we make the healthy choice the easy choice.
Mhm. By the way, Dr. Donna Pope raised the issues about the health professionals who are leading some of these health initiatives. Do you know of any who's doing some major work in the health industry in Nebraska who help deal with some of the public health issues and other things related to dealing with people of color? Is anybody out there that you can think of?
So what I would point out, we can get into names, but like almost like the what I think about is, are we doing a good job supporting really our nonprofit sector and partnering well with them? Because there are so many like nonprofits that do have good representation in terms of, people of color being part of them. Goes back to that, like the thing we were talking about, like certainly the representation could be better, by all means. But like one of the things I think about is you have umbrella groups like the North Omaha Community Care Council, the South Omaha Community Care Council, NACPOMA for the Native community, that are places where people come together to make sure that they're talking collaboratively. They're trying to work, across silos to make sure issues get elevated and raised and get addressed. So I think like those umbrella groups are some of the one for the refugee community would be the Omaha Refugee Task Force. So like what you've got is collections of nonprofits and community leaders who are passionate about health issues come together to then try to address them through those umbrella groups. It's some of the things of like, do those groups have as much power and sway, which goes back to the earlier questions we were talking about of like, are people making sure to listen to those groups, to engage them, to build relationships with them? And obviously, like, that's not nearly as good as it should be. That's certainly opportunity for improvement.
So one question is looking at is, do we work with poor seniors? In other words, do we have a program for them? And then the other question is, if they have financial situations or challenges, how do you deal with that in a public health or if you work as a physician? Again, some of that obviously may be outside your bell curve or your bandwidth, but how do we deal with the composite, or you would call the comprehensive way of helping them if they're financially in trouble and they can't afford health care, or they don't have enough money to buy adequate or nutritional food? So the question base is begging us, how do we make a much more comprehensive model so that they don't get caught in some of these quagmires or these negative situations, that they're going to have some health indicators that are negative when they go back home or whatever?
So this is like a heartbreaking thing because Omaha actually had a really great model that was called the Build Health Challenge that Heartland Family Service was leading at their intergenerational center. And it was just this sort of thing of like, how do you partner with seniors to make sure their needs are getting addressed?
Mm-hmm.
It was something that involved the health department as well as the healthcare systems. Uh, and it really was like they got that funding to be able to do that right before COVID hit. When COVID hit, instead of bringing people to the community center, they were going door to door, checking on people and asking how they're doing. They figured out ways to provide social support for everybody during that time. Like when there was a thing of like somebody's needs got addressed, was it transportation or just like they figured out how to network people together and have enough social support so they were working together to do that. And the sad part was that the when the funding from the National Foundation ran out, there wasn't enough support locally to keep that going. And that is again, it's like it's heartbreaking that that ended up happening because it was a really great model of how you do exactly what the question's about.
Someone just raised a point here. It says, how do we provide quality health care between those who have and can afford private insurance and those who are on Medicare rather? My experience is those who have insurance receive a high quality medical services. Then the other part of that is how do we move towards a country where no matter where your income is or socioeconomic status, you can receive the same quality of health care as those who have? And we only have about 10 minutes left, so I wanted to get to a couple other questions too. But yeah, I kind
That's a
of
heck of a question. Melanie, I'm going to let you go first on this.
It's a heck of a question. I think a lot of this goes back to what Andy talked about before, right? As a country, apologies, my dogs are reacting. As a country, we have to decide, is healthcare a right? And if it is, then there are different ways of going about that. It doesn't necessarily have to be a single payer system, but if healthcare is a right, we assure basic access to things. We assure basic access to medicine. We assure basic access to PCPs. We assure basic access to your cancer screenings and things like that. Even unfortunately with Medicaid, I have a lot of restrictions of trying to get you home health is really, really hard. What medicines I'm allowed to use is really, really hard. And so when people are making decisions about what gets covered, that's really, thank you for that, Andy. That's really what it comes down to is, do we believe everyone as a country deserves access? And if so, then our models need to follow that.
Good. One of the things that jumped out at me is that we got to do a much better job for communicating in our communities and with providers as well as patients, as well as community advocates, and as I say, public health. And one of the things I've been somewhat surprised as I've gotten a little bit more involved is the silo mentality in Nebraska and the lack of cross-fertilization among even the health providers, whether it be the medical center, CHI, you name it, and man, you name it. And so we got to do a better job. But also the thing we got to do is get the demographics out there because again, if we don't know what the existing conditions are or what the data is, how do we know if we're improving? So again, that's another thing that we need to do a little bit better job is communicating demographics, but also making sure we got the credible messenger. Because I think as Donna Pope just alluded to, who are those kind of the town criers in the medical community who are the vanguards? And I can't think of anyone that I can interact with who I can always talk to dealing with race issues in healthcare in any system in a sense. And so my point is, if I don't know anybody, what about other folks out there? But those are things we got to kind of address and talk with. And we're getting close to the end, but I want to ask both of you a question is that as you work in the field that you do in your respective areas, and I know you look at certain things, how do you know if we're getting better or worse based upon your vantage point where you're at? In other words, as a physician, you may look at a client or a patient as that, but from a bigger picture, how do you know if we're getting better in Nebraska or not? And then, Andy, in your case, you actually see some data, or you may not see data, but how do you measure your effectiveness or are we getting better as a state? Kind of a loaded question. Kind of you can drive a truck through it, but I really want to know how do you consider success in what you do? Did I hear crickets or something, or did I ask a question?
You want me to go first?
Was
I
I
was
thinking
just
bonnets
seeing
or
if
something?
Melanie
Did
wanted
you
to
hear
jump in.
what I was saying? Okay, go ahead.
So the bookends for public health in terms of how you measure how healthy we are as a community really are like infant mortality and life expectancy.
Okay.
The for so long life expectancy was just going up, going up, going up, and so we sort of lost track of that's our scoreboard. That's how we measure, are we getting healthier, are we getting better as as a community, as a nation, all of that sort of stuff. You could get that data like nationally, but it's really hard to get as a state and even harder to get locally. And then to get to the point where you had that the life expectancy data or the infant mortality data like broken down so that you had it by different racial groups or you had it broken down by different geographies, you get into challenges of like, particularly with infant mortality, because the good thing is we actually don't lose very many children before their first birthday. So you get into the challenge of small numbers, but like there are ways around these things if somebody cares enough to figure it out. And I'll give an example of like the life expectancy data for our Native community. For years, it was just not shown, not known, all that sort of stuff. And it's the thing of somebody has to ask, well, how many years do we have to put together so we actually like have that data and can do that? And you can get there. You may have to put together 3 years worth of data or 5 years worth of data to do it, but you can actually get it figured out. So life expectancy is really kind of the best scoreboard that we have. It's the thing of like, it's a downstream measure, you know, so you have to figure out what are the things that are going to drive that and improve that, and that you have to focus on that. And as we talked about, like being able to improve infant mortality, maternal mortality would be a great thing to do that would affect life expectancy, all those other things that we talked about, drug overdose deaths, suicides, homicides, all of those are other important things to do that would, if you were improving those things and seeing that, then you're going to be improving everything in terms of life expectancy too.
Dr. Melanie, what would you see as your outcomes or success models in what you do?
Yeah, I think to Andy's point, you can't improve what you're not measuring. And so that is really important. We need to continue to advocate that we do have data and we have points. It's easy to say I'm the best and not actually back that up with data. And, I think we've done that as a country for a while. We have the best healthcare in the world, but when you look at the data, the numbers show differently. For me, and this is not necessarily a big metric, but I would really like as a primary care doc that I'm not seeing you after the cancer diagnosis and now I'm telling you it's metastatic when we could have had a colonoscopy and prevented this, or the breast cancer, or the complications of diabetes. To me, that's how we really measure as a system. And it's to the point earlier of some have a lot and some barely have any access. How do we close that gap so that there is at least a baseline of expectation of healthcare across the country? I haven't figured out how to achieve that yet, and definitely am not batting 100%. But I think seeing that gap close of the preventable things would be my mark of success.
Good. As you mentioned, I was on the board of Charles Drew Health Center some years ago, and one of the treasurer who originally, I think it was a treasurer, he did finance at Creighton, and he said something to me that the way that they sometimes figure out physicians' importance or significance, how much money they generate. He didn't talk about the patient quality care. He think it was about money at that time, which I found somewhat surprising. Again, he's probably not working anymore, but he shared that with me. It's kind of as a kind of way of looking at that. But again, we have to be beyond just looking at money all the time when we're talking about people's lives and so on. We're down to the last part of our show, but one other person made a comment, kind of I don't know if it's satirical or whatever. He says we need to stop paying some of our healthcare directors in the community sort of high salaries and do more with other folks. So it's kind of interesting to hear that thrown out at us. But I do know there is a income gap that we need to be talking about down the road to make sure that we're not spending too much money on administrative versus direct care to many of the patients and so on. Paul, it says, can the country track income of baby families when we go home from the hospital? We can improve on that. He kind of threw that out. We need to track more after they leave the hospital. We're down to our last couple of minutes. I just want to give each one of you a chance for any closing comments as we wind down. Anything you'd like to say to the participants before we close out? And doesn't matter who goes first.
But real quick, just because I would hate for Paul to throw that question out there and to not have us address it at all, and then I'll circle back. There are some things that hospitals are required to report. And those that, typically, whatever. If you see a TB patient, or somebody, has particular types of food poisoning, like all of those things get reported and get tracked and all of that sort of thing. The thing that gets tough is that healthcare systems have so much data, but figuring out how to be able to leverage it across different healthcare systems and track it over time is a huge challenge that we could do a whole show on that as one of the challenges that we face as a community, is being able to have access to that data and track it and be able to use it appropriately. And now, Ajmal, your question was anything else that we want to sort of throw out there. I'll go back to what I said at the beginning. And we've talked about it multiple times, we don't have a commitment as a nation to providing, at least a solid level of care to everybody. We still are in a place where some people are deserving and other people aren't, is at least the model that we've built our sort of, healthcare and health coverage, around. And until we get to, as Dr. Menning said, it's both the like healthcare as when you get sick and you need, some sort of treatment to get back on your feet, to see that as something that people have a right and should have an expectation, just because again they're breathing in and out, and just as a fellow human being they matter enough to be able to do that. That that foundation needs to be there, and it's not there right now. So it's really tough to build something solid when you don't have that foundation in place. The other part is it's not just a health thing. We see this everywhere in any sort of system that we have, of there's just not that commitment to making sure that we're trying to see as many people thrive in our community as possible. And, why do you want more sick people or more poor people or whatever? And again, trade-offs are real. We have to figure
And then
ways out to be able
Dr.
to,
Manning have closer also.
yeah, to navigate that.
Yeah.
And so, go ahead, Melanie.
Yeah, no, I can't do better than Andy did, but I think, one of the important things is this, and having community forums like this where we can talk and we can talk real about the issues that go on and the different factors that are putting pressure on different systems. It is not an easy solution. It's not it's not an easy way to fix things, and we definitely have to get to a point where we decide as a country whether healthcare is something everyone deserves or not. But then how we move forward from there is the conversations like this and looking at how do we envision a better system, and the only way to do that is making sure everybody is at the table and has an equal seat at the table to be able to share those perspectives.
Good. Well, folks, I'd like to thank both of you, Dr. Melody Manning, and then Andy, who's been well known in the community for community health and so on. Hopefully, we can do this again and spend a little bit more time on maybe drilling down on some other issues that came up. But I really appreciate you being here today. And as we always end our program by saying, may the force be with you. Baroko.